Wonderful. All right. So let's see. I'll introduce myself. I'm Dr. Sheila Addison. My pronouns are she, her, hers. I am the secretary of the Queer and Trans Advocacy Network, which is the temporary interest network of AMFT. So I'm an LMFT in Oakland, California, where I have a private practice and supervise interns. And I will also be joining the faculty of Antioch Seattle's MFT program starting this summer. So I'll be relocating in a couple of months here. Alex?
So I'm Alexian Taffy, pronouns they, them. I'm the chair-elect for the Queer and Trans Advocacy Network with AMFT. I'm based on Dakota Anishinaabe land, currently known as Minneapolis, Minnesota. I mostly run a private group practice of trans and non-binary and queer folks, and I'm also adjunct faculty at the University of Wisconsin-Stout on the graduate certificate for sex therapy.
So we're going to go through a number of different topics that are relevant as we try and do our telehealth work in this new environment with our clients. And Alex, why don't you begin?
I will. So this is now in no way meant to be extensive and exhaustive. You know, we have an hour together, and Sheila and I have done our best to pull together our experience so far to share with all of you, both from pre-COVID-19 as well as during this pandemic. And so where we want to start is really safety, right? Safety is something that's really important to our trans and queer community. And one of the things that we want to consider with doing online therapy is safety, and what does it mean to attend to safety in an online environment. And of course, this is relevant to any clientele, right? So what we want to do is focusing a little bit more on trans and queer folks. And so starting from this idea that it's important to make a safety plan that's specific to online therapy, and there are forms that you can share with your clients so that they can make a safety plan with you that you can have on electronic health records. And if you have questions about that afterwards, I can tell you a little bit more about that. But what we want to focus on is how does this apply to trans and queer folks specifically? So first of all, I want us to think about the environment that trans and queer folks are likely to be in, right? It is likely that many of our clients are not going to be in an ideal environment. This might mean a number of things. For some of our folks, it might mean that they are not in private housing, right? We know that there is a higher rate of homelessness amongst LGBTQ folks, and especially amongst QT BIPOC LGBTQ folks, that is queer and trans folks that are also Black, Indigenous, or people of color. So already the environment might not be ideal. They might have roommates. If they're homeless or unstably housed, there could be couch surfing. And this goes for both younger people as well as older people. So the environment in itself might not be the most ideal. And so making sure that there is a safety plan, and by safety plan, I mean things like, you know what a safe word or a safe phrase that your client has chosen is, and that they might tell you during therapy to let you know, for example, that in that moment, they don't have privacy, but it might not be safe for them to say, hey, I actually don't have privacy right now. So to have kind of a code word or a code phrase agreed between you and the client so that you know that you're in less than ideal circumstances might be something that you need to establish before or early on when providing kind of telehealth services to your clients. So the environment might not be as ideal, and we'll say a little bit more about that also in terms of access and internet and later, but for now we're just focusing on safety. Part of the environment is also family relationship, right? We know that not all LGBTQ plus folks live in kind of accepting and welcoming family environments, and that could mean a range of things. And we'll talk a little bit about the differences between adults and minors in a moment, but it could mean things like a spouse who's not very accepting for trans and or non-binary folks, but also for queer folks in mixed orientation relationships. We know, for example, that there is a higher rate of violence that bisexual people, especially bisexual women and trans folks experience in relationship. Bi folks are often more likely to be in mixed orientation relationship. So those are things that we want to bear in mind when creating a safety plan, and why it is particularly important not to overlook this recommendation of creating a safety plan when working with your clients online. We also know that many of our clients are going to have a higher rate of suicidality. For trans and non-binary folks, the higher rate is 10 times that of the general population. So that's quite a large difference. So how we manage suicidality online is different than how we manage suicidality in the therapy room. So for example, in your safety plan with your client, have you included details such as what happens if there is a concern and you disappear from the screen and I have no way of getting in touch with you? We also know that it's not safe for many of our clients to call the police onto them. So do we have the number and the release of information of a trusted friend that we can call in case of emergency? Do we know which hospital they have a preference for, so that if we're communicating with a trusted person with the release of information in place and we're facilitating for our client to be admitted to hospital, for example, we have the information we need to maintain continuity of care and to ensure the best care we can for our clients. And there's so much more to say about each one of those points, but we really want to cover a range of points. When we're thinking about all of those things, we also want to think about the differences between adults and minors. For many for LGBTQ plus youth, there is simply not a safe environment in the home. And that can be on multiple levels, right? They might not have a safe environment at home because they're unstably housed as a family. And that's particularly true for, I think, LGBTQ folks of color based on statistics. But they might also be not in an accepting family. And so how can they feel safe when engaging in therapy with us? And for them, it is particularly important to have those keywords or key phrases that they can tell us to let us know, I can talk about this right now because somebody has just come into the room, for example. And they don't want to say that explicitly because then parents might think that they're hiding something, and that might kind of increase their lack of safety at home, for example. They might not be able to continue working with us on issues such as gender identity exploration or coming out issues or managing online bullying or whatever it is, or managing suicidality, whatever it is that they were working with us on when doing telehealth. So not only do we want to think about safety, we might want to also think about some coded way in which we can still do work with our clients in a way that maintains their safety. And so the differences are important to think about, because in the case of adults, we can do things like asking our adult clients to go and sit in a car, for example, and have a session in the car, which is not ideal, with their headphones on, if they don't feel safe at home. But for younger people, especially younger adolescents and children, that is simply not an option. So how can we think about their safety while also engaging in continuity of care? And finally, we want to think about what are ingenious ways in which we can support our clients in managing this less than ideal circumstances. And I'll give an example from my own practice. I have a client who I've seen for a long time. They're not in a safe home environment, and that they don't really have the option to go outside the house or to use a car, and they don't really feel safe talking or being on video at all. But they did feel safe texting through Signal, especially because on Signal there is a setting that you can select so that the texts disappear after an hour or 6 hours or a day. And so that really enabled this client to engage in a therapeutic process and feel safe at the same time. Now, is that therapeutic process ideal? No, it's not going to be as good as a video session or a phone session even, but it is better than nothing for somebody who has a high level of suicidality, who's managing depression, and it maintains the therapeutic connection. And actually, we were both surprised at how effective even just doing this via text, and we booked a specific time to do this was, and how we could still talk about how things were going, make a plan to kind of support not sliding into depressive symptom too much. For example, talking about the importance of routines, but also talking about strategies that they were engaging in to kind of manage the lack of privacy that they experience in the house. And so that wasn't ideal, but I could still provide some care to this client through this device, which is still acceptable in terms of our ethics of care. And especially in these unprecedented circumstances, we have been given some leeways around how we can communicate with our clients. We want to be careful and thoughtful with those leeways. It doesn't mean that anything goes, but it does mean that we can be creative on how to provide both safety and care to our clients.
I'll just add that a couple of other strategies I've heard clinicians have used is getting on a video call, but then using the chat function instead, just to type back and forth, or using there's a whiteboard function on Zoom where you can share drawings with one another. And that's been used both as a safety tool, but also just as a therapeutic activity.
Mm-hmm.
All right. We want to also acknowledge that the ability to engage in telehealth is very resource dependent. It requires that people have an appropriate device and have access to the internet. This goes for us as clinicians as well, since of course many times clinicians who are already occupying marginalized identities are also facing more financial difficulties and things like safety and housing security as well. So there, of course, are ideals, about having, a good up-to-date, laptop or desktop, and then, using something like a phone is considered much less ideal. But if that's what your client has access to, that may be what you're working with. Also, being willing to do something like a phone call rather than a video call, even if you're concerned that this might leave out some of the information you'd like to have about how the client is looking and seeming and moving. Internet access is also an issue, and for folks that only have poor quality internet, video is often not worth the effort because if you drop 2, 3, 4 times in a call, it interrupts the session so much that it becomes more about solving the internet problem than about building the relationship. One thing I've noticed in my practice is my last session at night usually goes from 7:30 to 8:30, and at about 8 o'clock, I strongly suspect a lot of people in my building start to jump on Netflix. And so I'll be working with a couple, and 2/3 of the way through the session, we'll start to have trouble with the quality of the call, or it will actually kick one of us out of the Zoom room and then back in. And this happened to me just last week. So it's really important for me, to make sure that in my telehealth consent, there's always information about exactly what we're going to do if we start to have trouble with access. Do I call you? Do you call me? Do we text? Do we switch to another medium? Do we call it a day? And I've heard some really resourceful solutions to the issues of internet access. Dunkin' Donuts supposedly has moved their routers to the outside wall of the store so that people can sit outside the store and pick up Wi-Fi signals. Folks have done similar kinds of things. Have found spots where they can sit outside around libraries, around cafes, places that are still running internet that might be accessible from someone outside. Obviously, that's not ideal, but again, we're working with what we can get. There also have been very low-cost internet packages offered by some of the large providers, and providing some of those resources to my clients is what's been able to help us carry on our therapy in several situations. So it's really important that we stay on top of information to have suggestions and resources ready. If you don't have a computer, can you use, a cell phone? If your cell phone is broken, could you borrow a friend's, phone? You can do a sort of, hands-free exchange if someone is willing to lend you their phone for an hour a week and drop it off and then pick it up again. The other thing that has really been evident working myself in the Bay Area is having the space for a quote ideal kind of setup, because when you look at information about how to do good telehealth, it's often assuming that everybody has an office space with a desk and an adjustable chair and several light sources and a door, etc. And so when I have taken some refresher courses recently on telehealth to make sure that I'm brushed up and have the kind of best ideas about how to do this. You know, I've seen folks say, well, you know, you got to talk to your client about how to position their camera and laptop because we want them to have a good setup as well. These are from Person-Centered Technology. Quick course on telehealth, and they're great. They're a fantastic resource. I use them all the time. But their quick telehealth setup course was like, oh, here's information on how to have the ideal lighting, and here's information on the ideal gaze angle between you and your client. And honestly, what's really happening in many of my cases is that, you know, folks are sitting with a phone in their hand on their bed, because in San Francisco, many times folks are renting one bedroom out of a shared house, and that's the only private space they have. Or I have a couple that is sitting in such a foreshortened space because they share a studio or they have a teeny tiny bedroom that they're in, so that they can't sit far enough back from the camera in order to get good space between the two of them. So being really adaptable is incredibly important. The last thing about resources in terms of use of telehealth is that sometimes our clients are expressing discomfort using video, especially if they have some dysphoria around their bodies, around their gender presentation, if they're having difficulty accessing things like getting a good haircut that reinforces their preferred gender expression, right? Or, you know, keeping up their hair color. Or dressing in the way that they feel most comfortable if they're at home with family that's unsupportive. And everyone should know, if you're doing telehealth, what are some options for helping your client if they are uncomfortable looking at themselves? Of course, one way to do it is for them to just not use the camera, but if they are okay with us seeing them, they just don't want to look at themselves, then that problem can be solved, you know, by turning off their self view a lot of the time. So I'm mostly familiar with Zoom. The typical view that it gives me is myself at the top and a speaker in the main window. If I go up to the top right corner, there's a tab that says Gallery View that will appear. And if I click that, then I get myself and the other person side by side. And if I go again, float up to the top corner, there's a hidden menu that offers me the opportunity to hide my self view. At that point, then all I can see is the other person. And so for a client who's uncomfortable with looking at themselves, but willing to still be seen, rather than saying, well, let's just do a phone call or put a Post-it note over the camera or just turn your camera off completely, this is one way to compromise. If you cover the camera, that means that no one gets to see the client. But if the client is okay with you seeing them, it's nice to know how to hide windows. So I really feel like when we're talking about how to use the resources that we have available to us, these kinds of practices that we may be working with our own clients around, acceptance, equanimity, this is just how it is right now, flexibility, let's work with what we've got, being gracious and kind to ourselves, by the way, as well as to our clients. When I had this couple session interrupted multiple times, it was certainly easy for me to want to get down on myself, but my clients were very kind about it and willing to keep working in this difficult emotional place. And so I followed their lead. And finally, that sense of curiosity that we cultivate as therapists. What do we have? What can we do? What is possible? I feel are the ways that are helping me to work in this time.
Absolutely. Oh, can I just add a couple of things,
Yes,
Sheila?
sure.
Absolutely. I love everything you said, and I just wanted to add a couple of things. One about flexibility, especially as family therapists. Sometimes also LGBTQ folks are parents, and we might also be parents. And so one of the things that can happen is that you might have to also adapt your schedule. So for example, I have a couple who has a young toddler, and now I see them after the toddler's bedtime. And usually I wouldn't see people in the evening because I'm also a parent, but I've had to have some of that flexibility to maintain continuity of care and make sure that my clients' needs are met while balancing sustainability for me as a provider as well. And in the chat, there was also some useful comments about how on other platform like on Doxy, you can also hide your preview, similar to what you described on Zoom. And if people are really having difficulties or using a platform that doesn't allow for that, they could also put a Post-it on kind of top of their image to facilitate that. And the last thing I want to say is when we think about access to resources, it's also worth, if we're working with the practicum students or pre-licensure folks in our practices, it's also really important to think about what do they have access to? Because, for example, I have enough space that I can do therapy from home at the moment in a way that's HIPAA compliant and has enough privacy. But several of my pre-licensure folks and practicum students do not have that privilege because they live in much more of a shared space. They're younger. They don't have as many resources because of all the issues that we know LGBTQ plus folks face. And so making sure that there is still access to the office in a safe way. Everybody has got a space that they're the only person they access. They're doing telehealth from the office. They're able to sterilize everything and have it clean, and then the only person who use it. Whereas I've heard sometimes larger practices just stop giving any access to providers and assume that everybody can work from home. So if you are somebody who is working with kind of pre-licensure folks, that's something that you might also want to think about. Is there a way to give access to a safe office where they can do telehealth if they cannot do that from home?
I've also heard about both supervisors and therapists buying like cheap pairs of earbuds.
Yes.
and having them sent to clients or to supervisees because using some kind of earbud or other device is sometimes important if you have trouble with sound echoing. I also, kind of in the opposite of Alex, I've had to move an evening couple to an afternoon spot and move around 2 other afternoon clients because 1:30 to 2:30 is when their kids nap. And so that's the only time that I can see them.
Yeah.
All right, I want to move on and talk about some specific kinds of traumas that we're seeing come up around this pandemic and the shelter in place. One thing that I noticed just for myself early on, and I've heard it echoed from many other people, particularly, but not exclusively for folks I know who are middle-aged like myself or older, is that this pandemic is in some ways echoing experiences that we may have had in the 80s and 90s during the worst years of the HIV/AIDS epidemic in the United States and Europe. Because it was a time when we didn't necessarily know for a long time what was causing people to be so ill. We certainly did not have, and still do not have, a cure, but we also had no meaningful treatment. We didn't quite know for a long time how you could catch it. People were sometimes very scared to be close to other people, or very isolating of people who were ill, afraid to come in contact with them, you know, employing all kinds of protective gear, treating people almost as if they were radioactive, and this sense of fearfulness about other people and about contact and being close really has resurfaced some of that. And so I think, you know, particularly for folks who were, you know, working with and supporting gay men, or who were living through this as men who have sex with men, some of that stuff has come back up. I've also heard some of my even younger gay male clients talk about feeling so torn because since HIV became a more manageable disease, this sense of we will enjoy our sexual freedom as a way of cementing our survival capabilities and asserting our identity has become very important to them. And so now saying you need to stay in place, you need to minimize your contact with other people, is really bringing up issues about shame and issues about loss for them. I also have clients for whom it's evoking other mass traumas that they lived through. I have a client who lived through Hurricane Katrina and the aftermath in New Orleans, and said this whole sense of the infinite lockdown, of never knowing when anything will happen or get better, is really bringing up stuff for them. Others who lived through Hurricane Sandy, who have said similar kinds of things. So if your clients have some of those traumas in the background, I think the HIV/AIDS thing is very specifically cultural for queer folks, especially men who have sex with men, but just in general, anyone who's been through some kind of a mass trauma experience may have that reactivated. People have also written very elegantly about the fact that this is a strange kind of ambiguous loss that we're going through. There's a lot of grief. We don't have ways as a society of talking about the grief of not getting to go to your graduation or your prom, not getting to engage in community activities are important. They've just canceled San Francisco Pride for the first time ever. And I think people are really stunned and don't yet have a sense of what that's going to feel like when time comes, but there is already a sense of grief building. There are a lot of fears that come along with this as well. The fears of, I just wrote this as fear of going without, but so it can attach to anything. What if I can't get more of my medication? What if I can't get enough toilet paper? What if I can't get enough food? What if there isn't a food problem now, but there is one down the line? And this can be fearful kinds of experiences for anybody, but again, for folks who come from marginalized backgrounds, who may have had, more intense experiences with poverty, with homelessness, with lack of access to resources, with lack of ability to sort of dictate the circumstances of their own lives. These can be really, really triggering kinds of fears for them. It also sometimes means people have a great sense of how to survive without. But I'm having clients talking, in very intense ways about what it evokes for them just to be worried about the possibility of food insecurity, even if they do have enough income right now. Of course, there's the fear of death for ourselves or for loved ones, because we're still trying to understand what is the fatality rate of this disease. And I have clients who have very vulnerable older parents or vulnerable people in their own families, or who live themselves with chronic illnesses that make them vulnerable. And their fear can be really intense for them. Then there's this anticipatory grief. How long will this go on? What will I lose? If I've lost my senior year of high school, will I lose my freshman year of college, which was supposed to be a way for me to get away from my home and assert myself and maybe be able to come out a bit more? If I have a surgery scheduled that I really have been looking forward to in order to affirm my gender, am I going to lose access to that? Because some people already have lost much anticipated surgery dates, and now people are wondering, will my date also be pushed back, and for how long? And all of that, I think, just speaks to the extended time frame of this trauma. It just goes on and on and on. And, as we keep seeing shelter-in-place orders but get extended, and this talk of opening up, I think very sensibly gets met often with, we don't know yet, we're going to have to see, it's going to be very slow and careful. We just continue to sit in this trauma with no sense of when are things going to change? When will we have more choices or more control? And this is true for us as therapists as well as for our clients. Alex?
Yeah, absolutely. And the only thing I want to add is, I know for some of my clients, this trauma is also triggering kind of the isolation that they felt if there was some family rejection, or if they were very isolated as LGBTQ adolescents, that this physical distancing and this being in the house by themselves, it's really triggering for many people. It's really triggering all of those memories of being alone, of not being wanted. And so really attending to the fact that our bodies are in this constant fight, flight, or freeze response, and communicating that with clients can be really helpful. And so that's a good segue in the role of community to counter social isolation, right? So a lot of folks are feeling really isolated. They are feeling very impacted. They are scared of who they're going to lose and when are they going to lose them. We also have more people in our community often who are HIV positive. So there is a lot of fear, and we have higher rates of disabilities as well. So there's fear about who's going to be most impacted in our community as well. So community has a big role at the moment in people's mental health. And some of the things that we can attend to, and as therapists, is people's reluctance to engage in community online. At least I found that a lot of my clients are very reluctant to engage in community activities online. There can be a lot of social anxiety will be there. If it's something that it's for the general public, will they be accepting of me as a trans person, a non-binary person, or as a queer person? If it's LGBTQ plus specific, will they be accepting of me maybe because of my gender identity, or my race and ethnicity, or my spirituality? There's a lot of social anxiety that comes up for a lot of people when they want to engage with kind of in new community settings. And yet, at the same time, community is essential to kind of help feel people less isolated and less alone. So there are online support groups, and also there's group therapy online, but I think that often we need to scaffold our clients and facilitate them accessing those groups, accessing those resources, because people might be much more reluctant to engage, to just walk into an online room and not knowing who's there. So if we're running some of those resources, such as online support groups or group therapy online, what can we do to make sure that the language is welcoming? Then, to use a word from kind of more of the somatic world, we are orienting potential folks who are coming into our online support groups or group therapy to what they might expect. So this is the number of people that you might expect. These are the people, you know, not necessarily, obviously not names, but this group is centering the voices of LGBTQ plus folks. You know, in this group, we have values of inclusivity. So what this, we will ask you about your access needs, and we'll do what we can to meet your access needs. So whatever language you're using, are you using a language that's helping client orient to what they can expect out of your online support group or group therapy? And there are various things that are emerging. For example, just recently, Sheila shared with me, if you can click, sorry, Sheila, I realized that you've got control of the PowerPoint. Oh, no, maybe back, maybe the animation didn't work. That's okay. I'd added a little picture of an online support group that's being offered to LGBTQ folks by a higher institution organization, and I can share that with people afterwards if you're interested. But it's a free group for young adults, and it is for LGBTQ young adults, and people could just have to go through a small intake process, and it's a free resource, right? And often people, yes, thanks, Sheila has put my email in the chat. So if you like this resource, just email me. And we also know that often LGBTQ plus folks don't have access to health insurance, or might have high deductibles and not have enough income to meet those high deductibles. So what are the resources that are available to us as providers to expand our services? For example, in the city of Minneapolis, put together a pretty quick COVID-19 mental health relief fund that organizations could apply to pretty easily. It only took me about half an hour to apply. And we got a small pool of money to be able to offer services to City of Minneapolis residents. And through that grant, we are going to be able to offer 8 online groups for sex workers in the City of Minneapolis, 8 online groups for trans and non-binary folks, as well as some online supervision and mentoring for QT BIPOC providers who've been financially impacted by COVID-19, as well as some individual sessions for folks who are uninsured. So have you looked around to see what's available during this crisis to support you in maybe expanding services to LGBTQ plus community where you live? And also, can we help our clients to connect with community beyond therapy, right? Online support groups are great and group therapy is wonderful, but also we need to have a sense of social connection. So I know some of my clients are benefiting from being plugged into mutual aid networks. And locally we have queer and trans mutual aid networks, networks for disabled folks, networks based on neighborhoods and so on. And there are also online get-togethers and offerings that LGBTQ folks are putting together for broader community. For example, singer-songwriter Eli Conley, who's based in the Bay Area, actually, Sheila, is offering every Sunday night sing get-togethers at 7:30 p.m. Central Standard Time, 5:30 p.m. Pacific Standard Time, which I think it's 8:30 p.m. Eastern Standard Time. Look at me go with those time zones. But the opportunity to come and get together by with other LGBTQ plus folks and sing on Zoom can be really important. And that's a free offering, and that's available to anybody. And there are other free offerings that people are putting together. Dr. Pavini Moray on Wellsalium is putting together some LGBTQ focused and erotic offerings for people who want to kind of nurture their erotic lives or couple relationships and so on. So can we support our clients in feeling connected to community, not just through therapy, but in a variety of ways? And do we know what those resources are? And if you don't know those resources, please hit me up on email, and I'm sure happy to share those. Alrighty, so moving on, we have so much to tell you and so little time. And I was also trying to read on the chat. I'll do that later. So talking about social connection, one of the things that people are really missing is also intimacy, which is why I was also mentioning the resource of Wellstallium, for example, which has got several free offerings. And when Sheila is talking in a moment, I will put in more information in the chat. And then when the video is uploaded to YouTube, I'll put those resources in the comments too. So one of the things that people are missing out on is sexual intimacy. And so what does sexual intimacy look like under COVID-19, right? Especially when people might not have a regular sexual partner and might also not be engaging in monogamy. And Sheila will talk about consensual non-monogamy in particular in a moment. But one of the things we want to think about is how can we take a harm reduction approach during this time? So have we thought about and found out information about what does it look like to take a harm reduction approach during this time? Because just to say to people, just don't go and hook up, has never worked, and it's never going to work. It didn't work during the HIV crisis. It's not going to work during COVID-19. People are hitting up people on the street, and I've heard that from various clients and community members. And so if we want to help people think through what they're willing to risk and what they're not willing to risk, if they make this choice, how are other people going to be impacted? What are the resources that are available for people to better understand how they can engage sexually with others during this time? And as ever, LGBTQ plus communities are creative. So there are actually some wonderful resources. Ignacio Rivera has put together, I believe, some webinars on kind of how to hook up online virtually. There are people who are organizing kind of virtual circle jerks. Barbara Carrelas, I think, freed up one of her resources, which is how to have a touch-free orgasm. And much of her work, she's very open in talking about how much of her work it was really born out of the HIV crisis and this desire that people had to still connect sexually, but to do that in a safer way. So can we really access those resources for intimacy and connection and make sure that we share them with our client? And one of the things we also want to think about is that many of our clients will be engaging in sex work and do engage in sex work. And that there is a big overlap between queerness and sex work. And many of our sex worker clients don't have any way to make money often at the moment. They are worried about paying rent. They are worried about how they can engage in this work, especially if they are not very willing to engage online with people. And so I've had conversations with some of my clients about how do you access unemployment benefits now that they've been extended to self-employed people. Do you have to disclose that you're a sex worker, or can you just say that you have touch-based work that you can no longer engage in as a self-employed person, right? And so how can people access much needed resources while staying safe rather than putting themselves at risk because they're worried that if they don't pay rent, they might get kicked out of their house, for example. And also there have been a couple of really wonderful resources that sex workers specifically have put together for other sex workers. And so having access to all those resources for us as therapists to pass them on to our clients is incredibly important.
So I want to talk about couples and families for a bit as we move from sexual relationships to intimate relationships. About 2/3 of my work is with couples, and moving online for that very quickly has been quite an adventure and quite a learning experience for me. I had the privilege of doing a quick kind of primer on couple therapy online for the Couples and Intimate Relationship Network of AMFT. That is available actually for free on YouTube, and we can share that video link if you'd like, talking much more specifically about couple setups and what some options are for that. But so as I'm working with couples, some of the themes that are coming up, things like how do we do this sheltering in place right? And in some of my queer couples, we have complicating issues like having more than one partner, having vulnerable family members that they are still engaging in care for, and so what level of sterility essentially around other contacts is the right amount to have. I have a number of non-monogamous relationships that I work with, and trying to decide, well, if we are a living together household, down later on this list here, I've used the term pods, because people talked about their quarantine pods. If we live together, but we each have outside partners, can we also spend time with our outside partners? Well, what's their housing situation like? Well, if they live with multiple people, then that essentially brings all of those people into contact with our household. And so what does that mean for our household and then the other household that we might have contact with? So the arguments have been everything from as mundane as should you wear your shoes back in the house when you come home, to, you know, can you have dates with other people? Or can you have a partner over to our house? And if so, should you wear a mask and maintain social distancing with them, sit 6 feet apart, or can you have a makeout session with them? We just know in general that queer couples are more likely to have relationships across difference. Big age disparity, racial disparity, religious or cultural disparities. And so these issues, of course, are coming into play here. A gay couple that has one man who is older and who does have a lot of feelings coming up for him around the AIDS HIV crisis, who's partnered with a younger man who really has never seen AIDS as something that isn't manageable through the use of multi-drug therapy, something that you just live with as a chronic disease. They have very different ideas about exactly what is the right way to manage this social distancing and shelter in place. Those who, someone who comes from a culture where there's a lot of contact and a lot of responsibility for extended family may feel like it's very important to still go outside of their household and have contact with parents or siblings in an extended family, while a partner who comes from a more individualistic culture may say, no, that's not right. Well, the intent is that it's just us, and we should, just have video conferences with those folks instead of going over and sharing resources and checking on them. Also, just in my experience with working with queer couples, I think there's often more fluid boundaries with exes. It's much more common for people to have exes in their pool of friends. And so, continuing to have folks that you feel intimately connected to, that you may feel a certain kind of family sense with or responsibility for, even though they're not part of your household, is potentially a situation that folks are managing as well. I'm seeing folks who are in consensually non-monogamous relationships deal with all kinds of situations. For example, I have one client who is partnered with one other person. That person has a spouse who they live with in a multi-person household. In that multi-person household, there are a couple of people who are very vulnerable because of chronic medical conditions. And so my client, who is continuing to go to work because they are working in an essential job, and so is having a lot of contact with the public, decided right away that they would stop seeing their one and only partner. So they are sheltering in place as a solo person, occasionally having video dates with their partner, but also seeing that household have a lot of companionship, certainly have access to their other sexual partner, to their spouse, have a lot of mutual aid to rely on, while my client is feeling very, very lonely and very isolated and worrying about things like, well, what if my partner gets used to me not being a part of their life and a part of their routine? What will that mean for our relationship once this quarantine is over? But I'm also seeing folks who may have multiple parenting units, because when same-gender couples have kids, of course, there's often an outside person involved. And many times they maintain relationships with other folks who may have parenting relationships with children, or they may have children from a previous relationship in a blended household. And so what do we do if our kid has 3 different sets of parenting units, all of whom are used to sharing responsibilities for my child, for children from those other parenting units, etc. And so then they're managing things like, well, whose standards for hygiene, quarantine, social distancing do we follow? Do we maintain the same routine with our child of going to different households as we did before the shelter in place, or do we modify that? And if I'm relying on another household to carry part of the responsibility for parenting for my child, what do we do if then all of a sudden they want to shut their household down more and say, no, your child isn't coming over to see their other parent because I want to protect my household? So these are incredibly complex conversations that are often fraught with stuff from relationships that have ended. Sometimes they haven't always ended happily. And clients are trying to work this stuff out individually or in joint relationships in session. But I also do want to take a minute to talk about the strengths that we see in our particular populations, because it's been very interesting to observe, as hard as it has been on queer and trans folks sheltering in place, as hard as it's been on everybody, some folks are finding that there's actual benefits and unexpected positives. So for example, clients who are gender dysphoric, or who are non-binary, or who are transgender and feel that they don't comfortably get read as their appropriate gender, even folks who are just visibly queer, are sometimes finding that not having to be out in public all the time really takes a load off, because they're not running into microaggressions of people misgendering them, people being rude to them, and then wondering, is that because I'm visibly queer, or is it because I'm visibly trans? Not just carrying around the burden themselves of wondering who's going to be safe to interact with and who might be a threat to me. I'm seeing this with some of my racial minority clients as well, who are saying, not having to be visibly Black or brown or Asian in public is actually a real benefit these days. Also seeing folks who, because of the extended time at home, are getting a chance to really experiment with their gender presentation. Kids who, for example, were kind of curbing their desire to experiment with gender because of how it would go over at school, are now able to say, great, I've got months to grow my hair out because it's going to be fall before people see me again. Or I can suddenly radically change how I dress and wear my hair, and then just come back to school in the fall and say, this is who I am now, rather than this gradual kind of process. And so that's really actually exciting for them. Folks are getting to experience with socializing online via text and via video, and in some cases connecting to community that they hadn't had access to before because they were spending a lot of time at work or at school or in commutes. Folks are also, I think, getting more creative about reaching out in ways that they hadn't before, and finding ways of having community that they're really enjoying. And I'll point out that we know that queer and trans folks have a higher mental health usage than the general population. And frankly, I'm seeing in many ways that makes people more prepared. Some of my very anxious clients are saying, I've been training for this my whole life, sitting in a constant state of worrying that something bad's going to happen that I can't control. I'm there for that. That's what my whole therapy's been about. And so they, in many ways, are feeling like they're kind of the experts on how to manage a situation like this, and getting to enjoy that expertise in helping to comfort and support folks who maybe don't have experience with feeling uncomfortable in the world all of the time. And that's, we know from narrative therapy that being a kind of community of concern for folks and being able to be sort of an expert on how do you deal with problems and their influence is actually really supportive of people.
Absolutely. So just before we finish, as well as talking about strengths in our clients, we also want to talk for a moment just about how important self-care and self of the therapist is in this particular moment in time. We are impacted in real time by the same crisis that our clients are going through in a range of ways. And that is not often the case. It has been the case in very specific circumstances. Like, for example, some of the times that Sheila mentioned, like Hurricane Sandy or Katrina, but at the moment, we're also seeing the science evolve in front of our eyes. We might also be impacted by our own issues with family, such as, maybe uneasy relationships with co-parents or uneasy relationships with spouse, intimate partner violence. All of those things haven't stopped existing just because a pandemic is going on. So as well as being impacted by the pandemic, we're also being impacted by many of the same issues that our clients are facing around housing. We also know that LGBTQ plus folks, especially trans and non-binary folks of color, are often underemployed. They have, and also they're impacted by increased level of racism. I have some colleagues, Asian American colleagues who are also queer, who are feeling this impact of the increased racism in the world towards Asian American folks, which of course is not the first time that has kind of risen in the US, but that's impacting their capacity to show up for clients as well. If we live with disabilities, if we're disabled ourselves, this is something that's impacting us in very specific ways. So really making sure that we are paying attention to how is this pandemic impacting us? What are our resources and what are the areas in which we might lack resources is really important. As Sheila has mentioned, past trauma, including the HIV crisis, impacts many of us older folks, kind of 45 plus, I would say. And this is an anticipatory grief of what is our community going to look like after this, right? That we are also going through that. And often for some of us, for example, who might be where it might be common knowledge that we are disabled ourselves, we might be managing our clients' fears of losing us. And to a degree, like for example, clients from an attachment perspective are often scared of kind of losing their therapist. But I've had several clients who said, I started from being anxious about myself and about my family, and then we did all this good work in the last few weeks, and now I'm really worried about you dying. And that's always a fun position to be in, right? When you're helping your clients process their fear of you dying on them, when you're also managing your own fear of you dying on not just your clients, but your family and so on. So it is kind of an exceptional time. We might also feel isolated within collegiate community. I know that several LGBTQ plus practitioners struggle to feel connected if there aren't many visible LGBTQ plus colleagues in their area. So staying connected at the moment with other LGBTQ plus practitioners is really important. And we'll say a little bit more about why we wanted to do this, but also why both Sheila and I were involved right at the beginning with the Queer and Trans Advocacy Network. It is because we do believe in the power of connection amongst LGBTQ plus two-spirit therapists. And at this time, I think the power of connection is more important than ever.
So I want to say, first of all, thank you to all of you who made time to be with Alex and me today. Those of you who are QTAN members, thank you doubly so, because it's your membership that makes it possible for us to do these kinds of things. We've grown from a 25-year-old informal network, kind of started in the shadows of AAMFT, to one of the literally very first off the block interest networks when AAMFT formalized them. And we are now the second largest, actually, of the interest groups in AAMFT, and continuing to grow. We're actually approaching 400 members now. This year, we're really excited. We're going to be able to start bringing you a newsletter. We have a newsletter editor. We will be formally announcing at some point a work group on best practices with queer and trans clients that will be a part of our future goals. And just for that very community that Alex is talking about, those of you who are members, there are still spaces available in the Hangout that's going to happen this Friday, 4 to 5 Eastern, 1 to 2 Pacific. Information about that is available in our QTAN community forum and also on our QTAN webpage. So sign up if you would like to just hang and chat and check in about how you're doing with some other fellow QTAN members. I'll also point out the nominations are open for our chair-elect. Alex is going to be assuming the role of chair next year, and so we'll need a chair-elect to be ready and learning that role, and then also for the role of treasurer. And so if you or someone you know is interested in leadership, please go look in the network community page, and feel free to send us your nominations there. Those of you who are not members, we opened it up to non-members really kind of late, just yesterday, but I know that a number of people did join who weren't QTAN and AMFT members. You have to be an AMFT member to join, which you can do if you go to amft.org, and I put some arrows there to show where you would get information about membership and then join the organization. And then during your join or renewal process, or anytime mid-cycle, you can add membership in any of the interest networks, including QTAN there. And so we would welcome you to join us as we move forward. So thank you so much for being with us today. I'm going to end the slideshow. You can submit questions by chat function, although since we are just organized as a meeting, you also can turn the microphone on. I'm not 100% sure whether we can, is there a raise hand function? Ooh, there is. So you could also use the raise hand function if you had a question that you wanted to ask. That's by clicking on the participants button that will come up if you float over the bottom of your window, and it will open up a participants window that then allows you to raise your hand. And then you could turn on your mic and or camera if you want to and ask questions.
And I promise that if you email me, I'll share all the resources that I have access to. So feel free to do that. But any kind of couple of questions for the last few minutes? I don't see any in the chat. Oh, could you share?
The link for, yes, yeah. The link for videos on couples and intimacy. Yes. Let's see, what is the best way to do that? I'm going to pull up where I have that, and I'm going to see if I can paste that into chat. Sure. It's at the AAMFT's apparently official YouTube page, so the American Association for Marriage and Family Therapy, and I will paste the link here. There it is. And it's about an hour and a half long, working with couples in telehealth. I think it's called Telemental Health for Couples webinar.
And I have a comment that says, please mention the Facebook International Transgender Health Group. That's right. If you are, there is a great active Facebook group that's the Facebook International Transgender Health Group for folks who work with trans folks. I really recommend it. And I am also offering some kind of daily somatic check-ins in the morning around 8:20 US Central Standard Time that people are finding quite helpful. And then I'm uploading the videos afterwards to YouTube. So now it's become quite the library of kind of somatic exercises. And those can be shared with clients, and you can also use them yourself, or you can join me for the Facebook Live Monday to Friday. I talked about a few folks. I talked about Ignacio Rivera, who's an educator, Barbara Carrelas, who authored Urban Tantra, and she's the professional that has roots in kind of the AIDS, HIV epidemic crisis. I really recommend Barbara Carrelas' work, and she has work on fire breath orgasm, but also gender-free orgasm. So it's pretty trans-friendly work. The Facebook group in the chat. Yes, the Facebook International Transgender Health Group. I will copy that again in the chat. Sheila is kindly also typed Ignacio's and Barbara's names in the chat. I find that a great tool for clients is a book called Seeing Gender by Iris Gottlieb. Perfect. More sharing of resources.
Any other questions before we wrap up today? We'd love to pass along more info. Alex, I know you're a well of resources anytime I need them. Someone had originally asked about documentation that you attended. We don't have, again, we don't have anything formal from this because this is not a CEU offering meeting. But if you want to prove to a supervisor or employer or someone that you did attend, I guess, email us and we'll see how we can figure out how to make that happen.
Absolutely. And I mean, I've recently, our organization has been approved as a ASEC provider, and I wonder if this would qualify actually. So I think it does. I will check. And if you need one, you might get an evaluation from me. And if you fill that in, then I can send you a certificate. And it counts with WPATH.
Oh, someone says it counts with WPATH.
As a community-led event, absolutely.
Great. We would be glad to document that for your WPATH needs.
Yes, and if you need this also for your ASEC education, so American Association of Sex Educators, Counselors, and Therapists, I think I can make that happen.
I'll also just mention, a couple of resources. So Ari Lev, who wrote Transforming Families, edited Transforming Families, wrote, she offers via her Tigris Institute, the Institute for Gender and something Studies, I think. Anyway, Ari has a bi-weekly supervision and consultation group about specifically working with transgender clients of all ages. And you can get on her mailing list very easily. And she is a WPATH supervisor and also ASEC supervisor. You can Google her from her info. I just put her name in the chat. I'll also say that for a few months before and after the holidays, I was running just a general monthly consultation group about working with any issues regarding queer and trans clients, but particularly couples and families. I've had to put that kind of on ice for a little bit, but if folks are interested, I can put my name, my email in the chat here, and you certainly can get in touch, and I'll let you know if and when I'm ready to start that up. So anything from you, Alex?
I think, I will do a little self-plug, actually. I know I've been told by folks that reading Life Isn't Binary, which was the latest book that John Barker and I wrote, has been really affirming for people who might be stuck with not so very accepting families. And it's also a really good book to gift families or to recommend for folks to read. And also if you are working with families where the cis parents or spouses are having a hard time understanding what a trans or non-binary person is going through, How to Understand Your Gender, which is another book by John Barker and I, can be a really good resource. Yeah, I think that's it. Thank you so much for, somebody else is adding comments. Yes, I feel like, as somebody has mentioned, I work with queer and trans people of color, primarily in Detroit, and the issue about gender nonconforming girls, women, particularly Black masculine girls, wearing masks are being accosted in the grocery store. Is anyone else hearing about this triggering experiences? Yes, this is absolutely an issue, and that could be a whole other hour of discussion, but just wanted to validate that absolutely that's an experience that I'm hearing, not just from clients, but by community members and friends as well, or QD BIPOC folks. This is an issue for sure.
Also very much so in the Bay Area, since now we do have a mask requirement in place in the counties around the Bay Area for essentially anything outside of your home other than exercise or riding in a car with members of your own household. And so this is creating tremendous anxiety for particularly Black folks, but also brown folks around how they're going to be received, and essentially creating a sort of you can't win for losing kind of situation, because if you don't wear the mask, you're more likely to get harassed by law enforcement for violating the ordinance, and if you do, you're likely to get treated as a criminal. And it's absolutely an issue that I think we're just going to have to be very present for our clients about, and to talk about how does one carry oneself? How does one signal or even code switch through one's clothing, one's mask style, one's bearing, to try and maintain safety? What are the things that they can do to maintain safety as they go out?
Absolutely. That. And I'll actually do one more plug about an offering that one of my mentees, Kim Sherva, is doing in May. They will be offering a webinar on how to support mental health providers who are not Asian American Pacific Islanders in addressing the racism the Asian American and Pacific Islanders clients are facing in this particular time. That'll be on May 15. It's run independently through my group practice. So if you're interested in that, email me and I'll send you details for the registration. One last comment that will take are the resources that the AMFT can provide about advocating with licensing boards and Medicaid panels about allowing telehealth without video. Indiana and Kentucky both have some restriction. I would really recommend getting in contact with the family team, and especially if it's state specific. Many state groups within MFT have got a family team whose job is really to advocate on a state level for those legal issues. So that would be the best point of contact on those kind of issues.
And finally,
yeah,
our social media
yes.
person, I don't know quite our official title, but our social media person, Nellie Morris, mentions, please follow our Q10 Facebook page and group for updates on future events and opportunities, ask questions, have conversations. That's at facebook.com/QTANAAMFT. That's there in chat as well. And again, if you are not a member, please consider joining us if you're already part of AMFT. And if you're not a part of AMFT, consider joining as well. We would love to have you be a part of continuing to grow this group and providing more resources going forward. Thank you all for your time so much. Thanks for being with us.
Thank you for attending, and thank you for your grace as we pulled this together pretty quickly. And I hope it was helpful to you and your practice.
Thanks, everyone. Stay safe, stay healthy. Best to you, and have a good evening.
Take care. Bye.